The cat is sitting on my paper, but I think Wilko, you're next. Wilko is from Amsterdam.
Thank you, Sharon. I'm looking for my presentation. Actually, I'm not from Amsterdam, but from Utrecht, but that's nearby Amsterdam.
Sorry, I do that.
And I'm trying, yeah. Okay, so again, thank you for the invitation to present our work of the Dutch National Expertise Center for PXE in the Netherlands, which is in Utrecht, in the middle of the country. As you can see on this slides, we have here Utrecht, and it is indeed close by to Amsterdam. But the country itself is very small, but the interesting thing is that because it's small, it doesn't mean that there are less people inside. So we have a very densely population with more than 17 million inhabitants. And that means that in the Netherlands, the estimated prevalence of PXE is somewhere between 300 and 700 patients. So our expertise center was founded in 2013, and we received the national accreditation as an expertise center in 2018. And what really characterizes us is that we are working as a multidisciplinary team. I'm an internist by training, vascular medicine specialist, but we have ophthalmologist, radiologist, a clinical geneticist, a vascular surgeon, and a dermatologist. And we have weekly meetings to discuss patients and research. And so far we have screened 371 patients, of whom 340 are proven to have PXE. And if the prevalence of PXE in the Netherlands is 1 in 40,000, then we have identified almost 80% of the patients in the Netherlands. And if it's 1 in 25,000, then we have around 50% identification of these patients. So we see 4 new patients each month, and we are hosting the so-called Dutch PXE Natural History Study, which was also started in 2013. And we do annual evaluations ranging from once in 5 years in the young patients till once a year in patients older than 40 years. And we do extensive evaluations of the eyes and the vasculature. So this is in essential the problem in PXE. This is the hydroxyapatite, the calcium formation in the body that is occurring in all of us, but in PXE patients, this is not completely inhibited as it should be. And here on the right side, you see tubes with decalcifications on the inner layer. And this is in fact what is occurring in PXE patients. And now the next slide, yes. So when I'm talking about the so-called arterial calcification, then we need to know the anatomy of the blood vessels in your body. So we have the arteries that bring the blood to the organs, and we have the veins returning the blood from the organs to the heart. As you can see, the wall of the arteries are much thicker than the wall of the veins. And in the inner layer of the wall, there is the so-called arterial calcification. So when I talk about arterial calcification, then I mean the calcification of the wall of the arteries. So I have very limited time to present our research, so I've chosen to present 3 studies. The first study, we studied how the calcification of the arteries is ongoing in PXE. In the second study, we addressed the question, what is the pyrophosphate level in PXE? And in the third study, we studied the question whether etidronate treatment is preventing calcification to occur in these PXE patients. So in the first study, we looked at the calcification, the arterial calcification in patients, and we studied in almost 300 PXE patients the calcifications by doing a whole body CT scan. And what we found is that when patients become older, the calcification of the arteries of the legs is increasing. And also when we look at the total body calcification, so that means the vasculature of the whole body, then there's also an increase by age. In 30 of these patients, we did a second CT scan around 4 years later. And here on the lower side of the slide, you can see the percentage increase in the arteries of the legs and the total body during 4 years follow-up. So we could calculate the percentage increase of arterial calcification per year for the vasculature in the legs. That was around 8.5% per year. And the vasculature of the whole body, that was around 12% per year. And we also had a look where the calcifications occurs. Now, we already knew that the calcification is in the medial wall, medial part of the artery wall. And we noticed that the calcification is predominantly present in the legs. As you can see, the arteries of the legs, also the carotid arteries in the neck. So this is nearby the skull. And the third predominant location is the arteries of the arms. In the second study, we studied pyrophosphate. And pyrophosphate is a very strong inhibitor of calcification. And we already knew from my studies that this may be impaired in PXE. So we studied in more than 200 patients the pyrophosphate levels in close collaboration with colleagues from Budapest that measured the pyrophosphate levels in these patients. And you can see that the patients have an average around 0.5, which is 60% lower compared with 30 healthy controls, which were mostly the spouses of these patients. And here on the right side, you can see again that the patients in red have a much lower level of pyrophosphate compared with the healthy controls. And the second finding in this study was that there was an increase by age. And why this happens is not completely understood yet. So when you have a look at the molecular structure of pyrophosphate, then you see that there is a close similarity with so-called bisphosphonates. And bisphosphonates are drugs that are being used for the treatment of osteoporosis. So bisphosphonates can be seen as analogues of pyrophosphate. And we already knew from a study of the research group in Jefferson University that knockout mice, so PXE mice, so to say, have this calcification here, brown on the lower parts. And this can be prevented or with etidronate treatments when you treat these mice with this bisphosphonate. However, when you treat these mice with another bisphosphonate, alendronate, this inhibition is not occurring. So there is something very special with this etidronate drug that indeed is able to reduce the calcification to occur. So this was studied in the TEMP study, where we studied the efficacy and the safety of 1-year etidronate treatment in PXE patients, which was a single-center, double-blind, placebo-controlled, randomized trial. And we studied the arterial calcification, the complications in the eyes, if they may occur, and safety of this treatment. And what we found was that in patients that were randomized to etidronate, the calcification was reduced compared with placebo. And we also found that when you looked at other vascular beds, not only of the legs, but of the vasculature of the rest in the body, then you see that this summation score, so to say, is in the same direction. So the etidronate has less calcification compared with patients treated with placebo. Regarding safety, although we used a relatively high dose of etidronate, this was well tolerated in the patients. We didn't see any serious side effects. However, there were some temporary increases in phosphate during each period that the patients used the drug, but this is already known as this drug is now almost 50 years old. Now we are extended the evaluations in the so-called TEMP2 cohort because etidronate as a drug is not available anymore for regular use. However, we are working on a restart of the production in the Netherlands, and currently We are treating 93 patients where we will study the efficacy and safety, but now during a longer period, so during 5 years. And we expect the first results after 2.5-year treatment next year. So to conclude, PXE patients have a progressive arterial calcification, predominantly in the legs and the vessels to the brain. Secondly, pyrophosphate is reduced by around 60% in PXE patients compared with healthy controls. Etidronate significantly reduces arterial calcification in PXE, and this drug is safe during 1-year treatment. And I'd like to end to express the sponsors of the TEMP study because thanks to these people, we were able to execute the study. And among them was PXE Netherlands, the Dutch patient group that made it possible to do this study. And this ends my presentation, and I'm happy to address the questions you may have.
Wonderful, thank you very much. So we have a comment question in the chat. There have been a few trials on treatments, supplements for PXE prevention based on current evidence and the risk profiles of these treatments and supplements. Is there a recommendation for patients? If so, with whom should patients discuss starting? And before you answer that, Wilko, I'll just answer it broadly. PXE International regularly convenes all of these folks that you're seeing here, and our recommendation is not to try anything outside of a clinical trial at this time so that the trials actually get the power, the people they need, and that none of these treatments are ready for prime time, so to speak. Go ahead, Wilko.
So you mean the supplementation of, I couldn't understand the question quite well. The supplementation of what?
So anything. What is your recommendation for treating PXE at this point?
Not to use any supplementation of any drug or drug that is available over the counter. I think that only the evidence from clinical trials can help us to find the right treatment in PXE.
And then another question was, would you advise every patient to take Etidronate?
No, I certainly would not recommend that. And I think that we are still in controlling and understanding this treatment. It is promising, but we need to learn from longer experience that we are now collecting, whether indeed also on the long term this drug is efficacious and safe to use. However, the drug is not available anymore, so it will be hardly impossible to get a drug, but then still I think that good science will give the quickest answers for all the PXE patients.
And then a final question. I've been taking Prolia, which is a trade name for an osteoporotic drug, for the past 3 years. Is it advisable to continue? And I'm just going to say, we've said we are not giving any medical advice over the internet, but in general, how would you answer that, Wilko?
So in general, so probably this patient uses this bisphosphonate for osteoporosis treatment, which has certain advices, how long and which dose. So far, we have no indication if any other bisphosphonate other than Etidronate has the same effects. I think that the people from the lab in Jefferson's already showed that there may be discrepancies between bisphosphonates. So I would not recommend to use another bisphosphonate as an alternative for Etidronate.
Great, thank you very much. Thanks very much, Wilko, for spending part of your Sunday afternoon with us, and that to each of the speakers so far as well, especially from Europe since it's late in the day.